I think those of who want to ask questions can
freely
ask questions,
so
no?
that
Because
yeah, they can. Dr. Janti, you told me I made some last minute changes in my slides.
Sure.
So it's like basically nutritional support, and then I added some CLD and NAFL and chronic pancreatitis.
That's wonderful.
So if you think you don't need those, you can just let me know.
Sure. That is perfect. Yeah.
Postgraduate means DM students or
DM and DMB. Nikki, you can start.
Yeah.
As they keep joining, you can start.
okay. Can you share your slides?
Sure, I'll do that.
Good evening, everybody. Welcome to this edition of our PG class. And today, for a change, we are not having a clinical case discussion. We are having a topic discussion on nutrition support. As you all know, nutrition is a very important topic, especially for a gastroenterologist. And in fact, the Department of Gastroenterology of All India Institute is known as Gastroenterology and Human Nutrition. Okay, so probably that was the important, they gave it to the premier institution department when they started it up. But unfortunately, the nutrition is not given that much important in the teaching curriculum or in day-to-day practice. I think it's a very important subject, and all gastroenterologists should know they should have sufficient knowledge about nutrition, how to advise their patients regarding nutrition. And now, as we are having the epidemic of obesity, and as we are having lots of patients with obesity and non-alcoholic fatty liver disease, it is all the more important that we give them good nutritional support as well as advice, and of course refer to dietitians for proper dietary management. So to discuss these issues, we have Ms. Ritu Sudhagar with us today. She is the Chief Dietitian of Dayanand Medical College and Hospital, Ludhiana, Punjab. Welcome, Ms. Ritu Sudhagar, to this session.
Thank you so much, Dr. Thomas. Thank you, Dr. Janti.
Just to introduce Ritu, she's from she's with Dr. Ajit Sood, and we've been quite interactive in the IBD forum. And I've heard her speak, and we have this huge nutrition program, it runs for weeks and months. And there somehow she includes old people like me also in that session. And so we had and it's always nice listening to the team from Ludhiana. So Dr. Ritu, you can take us around and discuss, okay?
Before the official talk starts, I want to tell something more about our speaker today. She is a chief dietitian, and she has got gold medalist in her master's from Punjab University, and she has experience of over 21 years in clinical nutrition, and she has keen interest in critical care, diseases of GI tract as well as diabetes mellitus. She is an elected member of the National Registration Board for Indian Dietetic Association, and she is a certified keto dietitian and awarded in a number of international conferences for work on ketogenic diet. She is a contributor of Indian keto recipes to the International League Against Epilepsy. An active member of the Crohn's and Colitis Foundation, she is actively working in association with Dr. Ajit Sood. And if you look at the net, you will find a large number of articles which are published by them, and especially the diet for Crohn's disease. She is an honorary member of the team providing consultation to the Ministry of Health and Family Welfare for setting up kitchens in government hospitals all over India. She has lots of publication, and she has a very good presence in the print as well as in the visual media. If you search YouTube, search the Google, you will find lots of references, lots of talks, etc. With these words, I would like to introduce Dr. Ritu to today's audience, and over to you, Ms. Ritu Sudhagar, for your talk.
Thank you. At the outset, I would really like to extend thank you to Dr. Janti and Dr. Thomas for having me here as a speaker today. It's indeed an honor, and hope I'm able to kind of, come up to the expectations today. So it's though the topic given was nutrition support in severe malnutrition. I'll be taking a few things here and there also. So, I mean, please bear with me. I might go off record at places, but it does happen, I think, when you start talking. And so I'm trying to move my slide, but it's not. Yeah.
On the, okay, it's
Yeah.
moved.
So it's like, why do most of the up to 60% of patients on admission, they are either at risk of malnutrition or they're already malnourished. And due to metabolic stress, inflammatory response, or catabolism, they quickly deteriorate in nutritional status. So, what are the conditions that often require nutritional support? Impaired nutrient ingestion, inability to consume enough orally, impaired digestion, absorption, metabolism, and even severe wasting or depressed growth are the reasons that give us that make it more important that we provide adequate nutrition support to the patients. So, nutrition support would help us to obtain a better clinical outcome and a speedy recovery. It would help prevent malnutrition and complications and also reduce morbidity and mortality amongst our patients. So, how do we go about planning a nutrition care process? I mean, nutritional intervention for the patient. First and the foremost thing as a part of nutrition care process is the nutrition assessment. Unless we know what the current status of that patient is, we actually cannot plan or decide a nutrition intervention for that patient. So nutritional status screening as well as assessment, this forms the first basic step when you wish to plan and decide a diet for a patient. So nutrition goals include assisting with nutrition. Excuse me, ma'am. I'll just need to change because I can't see half of my screen. I'll have to change the mode and just give me some
You can
time.
see here. We have no problem, but
No,
just
I,
you
I
see
can,
it.
I actually, yeah, now I can, yeah.
Okay, fine.
So nutrition goals include assisting with nutrition risk, identifying macro as well as micronutrient needs of the patient, and implementing a nutrition plan to meet those needs. So assessment, nutrition assessment and screening would include, it's like A, B, C, and D. So A would mean anthropometric measurements, B is the biochemical parameters or laboratory parameters, C is the clinical assessment or the clinical judgment by the physician, and D stands for a detailed diet or nutrition history of the patient. So what are the different tools that we can use there? There's too many actually, but of late these the few that I have mentioned are good enough. They give you a good idea of the nutritional screening status of the patient. So screening, first of all, some tools that can be used are MUST, that is Malnutrition Universal Screening Tool. MERT is a Malnutrition Inflammation Risk Tool. And then we have NRS 2002 and Nutrix score, which are basically used for inpatients. MUST and MERT can be used even for outpatients. And once we feel that the patients need further assessment, if they have a positive MUST and MERT score, they have to be taken up for assessment. And the most commonly and easy, I would say, tool is subjective global assessment. And it's also reliable, I would say. So others are like skeletal muscle percentage, fat-free mass index, and even L3-SMI, which would need a CT. So these are the different assessment tools that can be employed. So I'll just take one after another. So MUST is a very easy one and it has a 5-step process. So it would include checking the BMI, weight loss in the past 3 months, and decrease in nutritional intake in the past 4 or 5 days. So you have to calculate the score, uh, add them, and then step 4, after the total, you would know what is the score. So score 0 determines low risk, score 1 means medium risk, whereas score 2 means more high risk of the patient. And any patient who has score 2 or more has to be taken up for further assessment. So this is what MERT looks like. So MERT would quite similar to MUST, but just that it rather than decreased intake, it incorporates CRP, C-reactive protein. And a MERT score more than or equal to 3 would again require further nutrition assessment. Subjective global assessment is the assessment form that I'll be talking about. So it includes clinical history, that would be weight changes over the past 6 months, change in nutrient intake, and for how long that change has been there. Gastrointestinal symptoms which have persisted for more than 15 days, like diarrhea, constipation, vomiting, altered functional ability, and degree of stress which has been increased by the patient's illness. Next, it takes care of, it includes physical examination. So that would be like whether there's loss of muscle mass or subcutaneous fat, whether there's edema and ascites in the patient. So on the basis of this information, nutrition assessment can be rated as well nourished, moderately malnourished, or severely malnourished. So this is a tabulated form of subjective global assessment.
This is system, is it? This one, the previous one.
Then Apache 2 is a very commonly, used one, but I somehow I don't find it very easy to use. Subjective global assessment is a, quicker form, I would say, and equally reliable. So whenever we plan to, determine nutritional intake for a patient, very often you would come against this ideal body weight. So how do you calculate ideal body weight? There are few, you can see that there's few equations that I've given, but the easiest and quite reliable is height in centimeters minus 100. So if anyone has maybe 5 feet 1 inches tall, so that is about 154 centimeters minus 100. So it's 154 minus 100, and ideal body weight would be about 50 kgs for that person. And we often need to calculate adjusted body weight also, because more so in patients who are obese, you can't calculate calories as per the ideal body weight, because that obviously you may end up keeping the patient undernourished. And if you calculate the calories, protein as per the actual body weight, that could be too much for the patient. And so deriving at an adjusted body weight is a very good idea in such cases, wherein you can subtract, you can take the difference between actual body weight and the ideal body weight, multiplied by 0.25, that is 1/4 of the difference, and add it to the ideal body weight. So this would give you the adjusted body weight. And for obese patients, you can carry out all the calculations with the adjusted body weight rather than ideal body weight. So how do we calculate energy for the patients? You can use predictive equation, and this more or less fits well, whether in critically ill patients or even warded patients. So for non-ambulatory patients and critically ill patients, you can calculate as per 20 to 25 kilocalorie per kg body weight. Whereas for hypermetabolic and patients who need weight gain, who are underweight, you can go up to 30 to 35 kilocalories per kg body weight. And you can even use BMI for estimating caloric requirements. And so caloric requirements would be higher per kg body weight in patients who have lower BMI. But we have to be wary of the fact that a patient with significant weight loss, people who have a history of not having eaten for more than 10 days or have lost quite a bit of weight, they should be started on a refeeding calorie level, which is about 20 to 25 kilocalories per kg. And then they should be monitored, because what happens in any overzealous dietitian would do that. The moment you see a patient who's very undernourished, you just feel like overfeeding ki jaldi se theek ho jaye patient, you want to correct the nutritional status, just you just want to do it, but then without realizing that you may end up having the patient with complications. So it's always good to start at a refeeding caloric level and monitor. And once the patient is better, then we can gradually advance to a higher caloric goal, because this would help us with avoiding refeeding syndrome. So this, I'm sure you all know what refeeding syndrome is. That refeeding syndrome can be seen on when we start enteral nutrition or even parenteral nutrition for severely malnourished patients. And patients who have some fistulae, Crohn's, short bowel, who have had weight loss history, anorexia, have not been eating well, they are at a huge risk of developing refeeding syndrome when nutrition support is provided. And so it's usually characterized. And let me tell you that refeeding can actually go, I would say you would miss out on it. So it's very important that patients' electrolytes and all are taken care, I mean, monitored very regularly. And if ever you feel that the patient is going into a refeeding syndrome, even if it's you don't have a dietitian, you, I mean, if the dietitian doesn't realize that the patient is undergoing refeeding, you have to tell the dietitian to, kind of cut down on calories and slowly raise the calorie content over a period of a week or maybe 10 days. So refeeding can easily be prevented by gradual repletion of caloric goals over weeks, monitoring and supplementation of electrolytes and vitamins, and avoiding excess fluid and sodium administration. So when it comes to calculating energy, I mean nutrition support. So foremost thing is, when we calculate energy, carbohydrates are the sources that we talk of. So what is the percentage of carbohydrates that can be usually give to the patients? So up to 60% of the total calories usually they fit well for most of the patients from carbohydrates. So, and otherwise, if you calculate another ways, if you want to calculate from non-protein calories, then it would be 60% of the total non-protein calories. This is important because, many times what happens is that we go on and on giving higher protein with not enough calories. So that protein sparing action, we lose out on that, So enough carbohydrates in the diet are very important. Of course, you don't have to do too much of it, because that could lead to hyperglycemia also. So how do you calculate non-protein calories? So total calories minus the calories that come from protein. So if you decide on a particular amount of protein, say maybe 100 gram of protein is to be given to a patient who is to be fed on a 1600 calorie diet. So 100-gram protein means 400 calories. 1 gram of protein gives 4 calories. So 1600 minus 400 is 1200. So non-protein calories that your patient needs is 1200. So 60% of 1200 will give you the grams of carbohydrates that you need. I mean, the calories that you could get from carbohydrates for your patient. So similarly, when it comes to protein, we say about anything between 1 to 2 grams per kg ideal body weight of protein has to be fed to a patient depending upon the severity of illness. And we'll discuss later that different enteral formulas are available, and they basically differ in terms of the quality of protein, the type of protein that they have. So next source of energy would be fat. So once we've calculated carbohydrates, how much fat do we give? So it's usually, if it was 60%, up to 60% as carbs, it would be up to 30% as fats, and otherwise it would be 40% of the non-protein calories. So 60% of non-protein calories would be carbs, and 40% of non-protein calories would be fats. And when it comes to fats, we have to be wary of the thing that there can be saturated fats in the diet. There can be MOFA and POFA, and then we have some anti-inflammatory omega-3 POFA. So what is the ratio of omega-3 and omega-6 that we are giving? So just the amount of fat is not sufficient. Type of fat should also be something that should look into. Another source of fat, another type of fat, I would say, is medium chain triglycerides. And these are often suggested for use in patients with fat malabsorption, but they are not very palatable and also expensive. So, MCT oils and are easily available these days. MCT powders are available, so they can be used, but you have to be cautious, because MCT oil should not exceed the threshold dose for patient, as osmotic diarrhea may happen. And we should gradually, pep up the amount of MCTs that we add to the patient's diet. But we should remember that medium chain triglycerides will not be a source of essential fatty acids. So the diet has to be a combination of medium chain triglycerides and other fats, so that essential fatty acids can be, need for essential fatty acids can be met. Several methods that you can use for assessment of baseline fluid requirements. Maybe you can base it on the amount of energy or the calories that you plan to give to the patient. So 1 ml per calorie can be given. Otherwise, like 1500 ml for the first 20 kgs of the patient, and thereafter 20 ml for every kg over 20 kgs. It's a very simple, easy to calculate formula. So talking about a quick calculation, so energy, anything between 20 to 25 kilocalories per kg ideal body weight does well for a critical patient, and up to 60% of total calories from carbohydrates, up to 30% from fats, and saturated fats not more than 1/3 of total fat, that is 10% of total energy, and up to 10 to 15% of total energy should come from proteins. And besides these macronutrients, we have to be very careful about supplementing trace elements, vitamins, and minerals in the patient diet. So zinc, copper, selenium, chromium, manganese, all B vitamins for that matter, vitamin D, iron, sodium, and potassium are ones which need more emphasis, I would say. So we also have some immune modulators like omega-3, as I already mentioned. It's an anti-inflammatory. Also glutamine, arginine, vitamin A, beta carotene, and selenium, vitamin E we have already discussed. So all these nutrients should also be, I mean, not all patients would need this, but depending upon the condition of your patient, you can judge as to what immune modulators or which of these nutrients you would like to emphasize in your patient. So we, especially talking about vitamin B12, because B12 would be altered in patients who've undergone gastric resection or even some resection of the terminal ileum. So, and there are studies that show that 60% of vegetarian patients, they have some about stage 3 deficiency of vitamin B12. So it's all the more important that you monitor B12 levels in patients who are vegetarian. And zinc, as we know that excessive stool losses or high output fistulas, they do pose a need for supplemental zinc, and as such very little is absorbed from our diet. And unless there is good quality protein, complete protein in the diet, it will not help in its absorption. Whereas, and there are many polyphosphates or phytates, and even consumption of iron and calcium may hinder its absorption. So we have to be very careful about supplementing zinc. Similarly, iron, because we know that its bioavailability of regular heme iron is much less as compared to non-heme iron is much less as compared to heme iron, and the goal should be to normalize hemoglobin levels and iron stores. And we know that vitamin C can improve or enhance its absorption. So iron supplementation along with some supplements of vitamin C can really help a lot. So prebiotics and probiotics usually not talked about when we talk of critical care nutrition in general, but I feel that they're very important because gut microbes, they are very important for the health of our gut, and gut seems to control almost everything in our body, so, and more so diarrhea. So they are the probiotics, they have been proposed as a valuable addition to modulate gut microbiota. So what are prebiotics? They are basically non-digestible food ingredients or sort of fiber that can beneficially affect the host by selectively stimulating the growth or activity of a limited number of bacteria. So examples of prebiotics are fructooligosaccharides, inulin, lactulose, galacto-oligosaccharides. These prebiotics are found in our normal diet also, but then you'll find that most of commercial formulae, they do have enough amounts of prebiotics in their diet these days. And probiotics are viable microbial food ingredients that confer a benefit to the health of the host. And of course, we have supplements for probiotics as well other than natural food products. So when to start and why should we start enteral nutrition? So we know that there is a difference between simple versus test starvation. So when we are stressed, when a patient is stressed, endogenous fat is the poor source of energy, and we take up to glucose and protein metabolism, and because of which protein is broken down and lost at alarming rates. And so this is the reason why enteral nutrition or enteral support, nutrition support has to be, adequate nutrition support has to be provided. This is a very basic definition. You all know that, I'm sure. So it's like enteral nutrition is providing of nutrition directly into the gastrointestinal tract. It can be done either orally or through a tube. And as far as possible, we should try to initiate within 24 to 48 hours of hospitalization or presentation at a clinic. And um, what are the benefits? Like enteral feeding really helps to maintain intestinal mucosal integrity. It will help, recover microvilli, retain normal intestinal barrier and intestinal mucosal immunity. Hence, feeding is very important. And as already discussed, that it could be done through oral liquid formula supplement or through enteral tube formula, depending upon the condition of the patient. So when we talk of feedings, they can be of two types. They can be commercial, they can even be blenderized. So by blenderized feeds, what I mean is that, as we do it, we still do it, and we've been doing, or at least, our predecessors, they relied only on blenderized feeds, because at that point of time, commercial formulae were not really abundantly available, easily available, and they're very expensive. So blenderized feed is something like, you call khichdi feed, and you blend milk with some milk powder, corn flour, refined oil, or maybe some dal soup and such kind of ingredients. I mean, regular kitchen ingredients blenderized to form a feed. And commercial feed, commercial formula means the things which are available through industry. So when it comes to choosing between blenderized food versus commercial formula, so what? See, when it comes to blenderized, at one point of time, I have been a firm believer that blenderized food should be given, because I've always felt that it was more physiological, more normal. This is what we eat. But over the years, with experience, I have learned that blenderized food or feeds, they may be good for routine patients I mean, routine patients means there would be patients who are on tube feeding for some or the other reasons, warded patients also, but not for critical patients, because some reasons, like we actually cannot estimate exact nutrition content of the blenderized food. We cannot estimate the osmolality. To have 100% lactose free food or feed becomes difficult at times, not always. And since, hygiene could be an issue, and the way it's cooked, uh, you may not do it for the patient. It has to be a cook in the kitchen, and how they mix and prepare the formula, the blender used, whether it's clean or not. So all those things can lead to poor microbial quality. And it, even when we try to meet protein requirements, and we end up adding so much of milk powder to the feed, it usually becomes viscous as well. Commercial formulae, on the other hand, there are variety of commercial formulas available to suit different needs. So, and all would be complete and providing balanced nutrition to the patient. They could be low. They could have a osmolality anything between low to moderate. Most of them would be lactose and gluten free, commercially sterile, and I mean, they don't form a viscous fluid. So they have excellent tube flow. So when we talk of formulations, this commercial formulae, enteral formulations, you would have heard of elemental formulae, semi-elemental, polymeric. So what's the difference between these? So difference in these basically depends on the type of protein used. So polymeric, or the basic, most formulae would fall under this category, polymeric. So they have protein as whole protein, like it could be casein, it could be albumin, whey, it could even be soy. And fats would be a combination of MCTs and LCTs and complex carbohydrates. So that's a polymeric formula. When you talk of semi-elemental, carbohydrates would be simple sugars or glucose or even starch. Fats would mainly be MCTs for their easier absorption, and protein would be oligopeptides or partially hydrolyzed proteins for easier absorption. And elemental would have most basic form of protein, that is amino acids. It would have more MCTs than LCTs, and carbohydrate also would be as glucose polymers. So we have to, as physicians and as dietitians, we need to know the difference between the three, and under we have to choose like under what condition, what which one should we be preferring. So there is an observation that exocrine pancreatic function is reduced in sepsis, and due to this, there were concerns about digestion and absorption of whole protein formulae in critical illness, and that's how semi-elemental and elemental formulae probably came into existence. But not much clinical advantage could be shown for such a formula in critically ill patients. Therefore, whole protein formulae are appropriate in most patients. I'm not saying all patients, in most patients. Because see, these semi-elemental formulae and elemental, they'll be much more expensive than others, polymeric. And then there, at times, the taste with the elemental formula could be an issue, palatability. So we should just not blindly go in for semi-elemental and elemental thinking that they're more superior. If there is a need, if we think the patient needs, we definitely should. Otherwise, relying on polymeric formulae does well. So this is, I purposely added names because Dr. Jayanti wanted me to guide you all on the type of products available. And this in my, you know, experience, I've found that the residents, doctors, they really don't know the difference between the formulae available, the types available. So they would usually know just 2 or 3 names, and they end up writing that for every patient, other than what nutritional support. I mean, if they want to use it as oral nutrition supplement. And many times I still feel that they do go wrong in prescribing that. And when we go for rounds, we have to talk. I talk it out to the resident or the physician and have it changed as per whatever I think is more appropriate. So you actually, before writing the product, you should know uh, what
The
do they.
volume is low.
Ma'am, now is it
Now
okay?
it's better. Yeah, now it's okay.
Okay. So we need to know that what is that particular product offering, and why should it be used, and even the right quantity that has to be used. So there are a lot of products in the market by the name, I mean, which would be a balanced nutrition formula. So like different 3 or 4 major players in the market: Frezubin, Nestle, Abbott, and then Hexagon and Azura. So I've mainly named their formula. So anything like simple Frezubin, Resource Opti, Ensure Plus, Pentasure Balanced Nutrition, Essential Balanced Nutrition, Pediasure Advanced. These are all balanced kind of nutrition. So these are not high protein formula. They provide you more like up to 60 to 70% calories coming from 60% coming from carbohydrates, up to 30% coming from fats, and just 10% coming from protein. So in patients where you need that patients need more energy than protein, only in those cases I think balanced nutrition formulae fit well. Otherwise, there are other options available too. And so when the difference between Pediasure and Pediasure Advanced is that one is lactose free and the other is not. Pediasure Advanced is lactose free. So not all these formulae would be lactose free. So if your patient has diarrhea, or if you think that the patient needs a lactose free supplement, you have to specifically look for it. Similarly, a list of high protein formulae: Gabipro is by Frezubin, Resource High Protein is by Nestle, Pentasure HP, HP is high protein, Essential HP, the Oroalbumin, Glutina HP, these are all high protein formulae. These are not very high on calorie, and these are not balanced nutrition. These are extremely low in fat. So it's mainly protein that they provide. So many times we end up, blending two. Blending means maybe either in every diet, every feed, you mix little of balanced nutrition and add some high protein formula to make up for the protein content, because otherwise balanced nutrition formula doesn't have enough protein, right? And if you give only high protein, then you end up giving only protein and no calories, which again doesn't work, right? So otherwise you can mix in the same feed, or maybe 3 feeds a day of balanced nutrition and 3 feeds a day of high protein formula. So that's usually, I think a dietitian would be able to do that better, but you need to know why we do that. And oroalbumin and protein HP I've put as red because they basically protein, I mean egg albumin.
All these are available. All these are available.
These are all easily available. These are the ones which are very easily available. That's why I pan India. So that's why I mentioned only these. There are many. I know there is a brand by Claris. Claris has all these products, but I think that's usually available in Gujarat and those areas. So that's why this Nestle, Fresenius, Azura, and Abbott, these are all companies which have a pan India presence. Right. So then there are some specialty products like diabetes. So most of them will have DM or diabetes as a in the name, so that you can easily distinguish them. So Ensure Diabetes Care, which was previously Glucerna SR, right? And so diabetic products again will have a 30% fat, uh, 60% carbs, and 10 to 12% protein. See, when you go to this specialty products, it tend to be more expensive. Diabetic products will have added some fiber, right, more than the others. So we should not blindly just go in for anything. We have to determine what your patient needs. There are specialty hepatic products by the names I've already given. And so what special do they add to hepatic products? They usually have more branch chain amino acids added to it. So animal protein, content of animal protein, that is animal sources like whey, milk, so though that would be less. The source of protein would be more vegetable proteins. Of all these, pentasure hepatic is, and also most hepatic products are not very high in protein, because presuming that we end up using tube feeding patients who could have encephalopathy, and that common thought that when the patient is in encephalopathy, we have to restrict proteins to a very low level. So Fresubin, Hepa, Resource, NutriHep, these are hepatic products, good products, but have very moderate amount of protein in them. Pentasure hepatic has slightly higher protein, and Live Source is quite high on protein because it has a lot of branch chain amino acids, and that's how they market it. But it has a lot of animal protein also in it. So I mean, we have to be very wise while we choose a formula for our patient. There are renal care products. There will be different products for non-dialyzed and dialyzed patients. Uh, they would all be low electrolyte, but for dialyzed patients, we usually need higher protein. So hence the names Nepro HP and Nepro LP. These are the names these are the formulae by Abbott. Similarly, we have this Fresubin LP, Fresubin HP. So it's like a renal. Don't think that Fresubin HP is a high protein formula for a normal individual. No, it's the renal high protein formula. Semi-elemental usually available are Peptamen, Pentasure Critipep. Peptamen is by Nestle, Essential Peptide, Ensure Peptide. And we even have energy dense formula. That is like when there are certain conditions where your patient needs more energy per ml. So and nutrient dense, energy dense, I would say. So Pentasure 2 and Essential 2.25 is that if you mix them in the mentioned quantity, so they would provide about 2 kilocalories per ml of the feed.
How palatable are they?
Ma'am, they are very palatable. They are all very palatable.
The semi-elemental ones.
Even semi-elemental is quite palatable. It's the elemental which have issue with palatability.
How do you mix them? You mix them with milk or water or what?
Ma'am, see, if you are using them purely as a supplement, then they have to be mixed in water. And we usually recommend, we don't ask patients to use tap water, or I don't even rely on simple bottled water. If the patient is at home, I tell them to use boiled and cooled water. Otherwise, of course, we have to rely on bottled water. So whatever information you get on these products, right? So it's all like, energy. It's all that if you mix them with water. But if when I talked of those high protein formulae which have hardly any energy, but they're basically only protein. So those have to be, if you mix them in water, you do not actually get calories at all. So either you mix in a balanced nutrition formula, or maybe you mix them in milk, because then milk would give you the desired fat and energy other than what you get, proteins that you get from the formula. So these have to be planned, calculated when you give. Some very special formulae, like we have IBD specific formula, that is folate CD. We had Remetin, I think it's been called off the shelves. Modulin is an international formula by Nestle. Oncology specific, so Fresbin Onco, ProSure, Pentasure Immunomax. So usually these onco products, they have more omega-3 added to them, and higher energy and protein. Then we even have COPD product like Pulmocare, which has higher energy coming from fat than carbs. It's a low carb, high fat product. Two products which I really want to lay emphasis, and I want all of you to know, is, maybe you already know, but I just want to lay emphasis on it. That is MCT powder. So it's see, mild MCT oil is something that is oil that is very easily available, and it's been available since ages. But the common problem that I feel and I have encountered is that when you add these oils to the feed, to the liquid blended feed or whichever feed, most of it, remains attached to the tube, rice tube or whichever tube, because that's a plastic, so it has an affinity. So I think MCT powders are now available, and if you mix those with the feed, whatever you're giving, so they have a better miscibility and better availability. They would actually be delivered to the patient. So QMCT is one MCT powder. The company's name is Pro India. Essential MCT is by Azura, and Pure MCT is by I'm forgetting the name. It's not Aristo Pharma. So unfortunately, we have only these three options that I know of in MCT powder. And there is one very good product that is soluble fiber. So I have used it for my patients where I need fiber when we have constipation, or I've even used it for thickening the ostomy output for my patients wherever it was needed. So this is a wheat dextrin soluble fiber by the name Fibro Essential. So because if you were to add a fiber, and if you think of adding isabgol husk or something, it would swell up and make the feed very viscous. So that really doesn't work. This fiber is something that doesn't add to the viscosity of the feed, and serves the purpose. So this is something, these products are expensive, but then you can use if really there is a need, because
the soluble fiber is in the form of a powder again?
Yeah, it's a powder. It's a very fine powder.
So
And it is
like how many grams you would say for concentrate equivalent to isabgol powder? How many grams would it be?
So it's like I'm forgetting the exact thing, but about, I think 100 grams of this powder has about 50 grams of fiber. So if over the day, if you end up giving say 50 to 60, you can very easily give 25 to 30 grams of fiber through this. And even otherwise, most of these formulae, they do have some fiber, though it's in small amounts. So this can be used as a top up, wherever you feel that the patient needs more fiber and you're not able to meet those fiber requirements through the regular formulae that you have decided for the patient. This can be used as a top up in the feed.
It comes by the same name, is it? Soluble fiber.
Sorry?
The product in the market has the same name.
This Fibro Essential. Yeah, Fibro Essential is the market name, and the company's name is Azura. I only know of one company that makes this fiber. Yeah. So,
just any questions up to here? Please, PGs, any of you can ask any questions on assessment and requirement.
They can put it in chat box, no?
You can put it in chat box. Yeah.
Chat box, yeah.
Yeah, just keep putting in the chat box.
So do we have some questions already, or should I move ahead?
I don't think they have really put up the questions. Any of the questions, any type, how to formulate elemental diet for Crohn's disease. I think she's just coming to that topic, I suppose. I think, okay, you just keep putting the questions in the chat box. We'll answer that at the end. Okay, just keep adding. Okay, continue.
Okay, okay. Thank you, ma'am. So when we talk of enteral nutrition, ma'am, do you really want me to take this up? Access and modes and all?
Yeah. We need this. We need enteral nutrition, yes, and in very malnourished patients, some little bit about TPN. Enteral is most important.
TPN, ma'am, I haven't covered much because
not required. We're not using too much of TPN, but enteral is important. But we agreed, no? We'll cover enteral.
Yeah, enteral is the one which we have less knowledge.
So
we should know more about it.
Yeah.
So what are the factors, that help us in selection of an enteral route? So it's the physiology of the GI tract, what's the risk of aspiration, and the anticipated length of enteral support that would determine the type of route that we decide. So again, whether the requirement is for short-term or a long-term requirement, whether we want a pre-pyloric access or a post-pyloric access, and whether we would be feeding the patient through an infusion pump or through a gravity infusion bag. These are the things we have to decide. And so we know there are different routes. Tube feeding of course, first of all, the nutrition can be provided orally, or the tube can be nasogastric. It could be nasojejunal. Usually jejunal feeds are nasojejunal tubes are placed when long-term feeding is to be provided, or for when post-pyloric feeding is indicated. PEG or a percutaneous endoscopic gastrostomy is performed usually for long-term compromised patients, especially patients with the neurological issues, MNDs and all. So those patients are usually on PEG, and even feeding jejunostomy, surgical jejunostomy for long-term feeding in patients, usually with pancreatitis, esophageal surgeries and all. So this is a very commonly seen decision-making flow chart. So if the GI tract, whether we have to know whether the GI tract is functional or not. So if it is not, then of course we have to resort to parenteral nutrition. But if it is functional, so we need to know whether the tube feeding, for how long would the tube feeding last? If it's longer than 30 days, then we have to, choose something like enterostomy tube feeding, or if not, then we can have nasoenteric tube feeding, which could be nasojejunal, nasoduodenal, or nasogastric, and jejunostomy or gastrostomy. So this is what usually physicians would decide. And then what are the administration methods? The feeds could be provided as a bolus, that is intermittent at fixed intervals, all feed in a single go, or it could be continuous. And there is actually not enough evidence that one is superior to the other, but continuous is usually used where risk of aspiration is high. And I would say feeding is mainly need-based. Depending upon the condition of the patient, we have to decide whether to feed the patient as bolus or as continuous.
In a patient who's got cirrhosis and tense ascites, if you feed the patient, so what would your recommendation be? That's usually a problem, no? The patients are not able to eat, quantity is less. At the same time, you have to give them the nutrition. So what would be your suggestion?
Ma'am, you mean to say a patient who's taking orally?
Orally, but he's not able to take. So in many of the centers, they place a nasogastric tube and feed. And then we do not know whether to give a continuous feeding or to give a bolus feeding intermittently, and they're not able to, because of the tense ascites and abdominal distension, they're not able to take that many calories. It's a practical problem. So
in such patients, we do rely basically on continuous feed, or it could, many times what happens is that we give like 3 major meals maybe, right? Small amounts of major meals if the patient is able to take orally. And other than that, partial, it would be a combination of oral as well as tube feeding. And when it comes to tube feeding, my personal preference is continuous. More so in such patients where, due to ascites and all, patient's tolerance to food is less, because otherwise, if you give a bowl, there's no point giving very little as bolus. So when you want to actually feed the right amount as a bolus, patient has a lot of regurgitation and can end up vomiting. So in such patients, we usually prefer continuous feeding, but we use a bag rather than pumps, because pumps are actually used mainly only in the ICUs, at least in our hospital. So
that bag fluid will be more of a what's it called, prepared, no, commercial product.
Sorry.
It will be more of a commercial product that you'll be giving as continuous feed, no? Commercial.
Yes, ma'am. Actually, I would come to that later. But
Okay.
what happens is that usually, if we are giving continuous feed through a pump, then it definitely has to be a formula, because kitchen blenderized feeds are actually not, they don't go through the pump. Yeah, they do not pass. And you can use that gravity bag. If with the gravity bag, you can give kitchen blenderized feeds. But someone has to repeatedly keep checking if you think that if they usually wouldn't go at the rate that you decide. It's just that rather than bolus in a minute or two, you could have that feed being delivered to the patient in half an hour or so. So you can slightly control the rate, but not exactly as you can do in terms of a commercial formula or when you feed it with the pump. Okay, so when it's bolus feed, we usually suggest that we start with smaller volumes, and a usual gap is about 3 to 4 hours. And checking aspirate is a common practice in ICUs, though latest guidelines say that there is actually no need to check aspirates and the patients should be fed. So, but however, if aspirate continues to be more than 200 ml, and if you think that bolus feeds are not working well, we plan to move the patient to a continuous feed. And continuous feed, as we just discussed, can be through gravity bag or through pump. And advantages of continuous feed over bolus is that it will help get avoidance of distension, the lesser chances of regurgitation, and feeding can be initiated earlier than by bolus method, because you can start at a very small rate, and very drip kind of uh, feeds. And also complications like diarrhea, aspiration, and distension, they all can be taken care of. But one big disadvantage of continuous feed is like it's kind of non-physiological, because we wouldn't, if we think of ourselves, we wouldn't eat 24 hours. So it's like, from that point of view, bolus that is fixed 7 to 8 times a day, they seem to be more physiological, but then bolus feeds come with their own problems. So continuous, in critical patients, definitely continuous feeds are the preferred lot. So what are the, we talk of enteral nutrition, but then we may not always be able to feed the patient enterally. There are some contraindications to enteral nutrition, like absolute contraindications would be intestinal obstruction, if you have a paralytic ileus, impaired GI function, or if you have any doubt regarding adequacy of GI function. And relative like short bowel syndrome, intractable vomiting, severe diarrhea, and certain terminal illnesses where aspiration and risk of aspiration is high. So those cases we may not be able to actually feed patient enterally. And so all the contraindications to PN actually are to EN are the indications for PN. So all situations where enteral nutrition is not, you know, indicated, we have to go in for parenteral nutrition. So with enteral nutrition also, there can be certain complications. So common complications like they could be mechanical, where there could be risk of aspiration. These problems could be related to tubes. There could be gastrointestinal complications like nausea, diarrhea, etc. And there could even be some metabolic complications. So mechanical complications or issues usually are like irritation or infection, aspiration, tube clogging. And to some extent, these can be, some of these can be taken care of by using small bore tubes which are made with biocompatible materials. And even this gastrostomy or jejunostomy tubes, they should be large enough to fit the stoma, because if they're not, they can again lead to irritation and infection. Then tube clogging, which is a problem very commonly seen. So I'm sure most nursing staff take care, they know, they're well trained to take care of this. So feeds have to be flushed regularly before feeding and after feeding. So and one thing that we can do is that we should use feeding tube only for formula delivery. Many times what happens is that feeding tube is one feeding tube and it's used to you know uh, for medication and feed and whatever they want to. So that can at times clog the tube. So we have to be very careful. If this is not possible to have a feeding tube only for formula delivery, the we have to very religiously flush the tube with water before and after administering medications. So we have when we talk of enteral feed, few things that we have to really take care of is the sterile techniques, because if we are not able to do that, there is a risk of induction of diarrhea and infections. If possible, we can use a closed system, but closed system would only be possible through with the, I would say, this pumps or bags, not in bolus. And also we have some commercial formulae which I did not mention. We have a ready to hang, that is known as ready to hang, that's available. That initially very many years ago, Fresenius Kabi had lots of pre-prepared feeds. They would come in a bag along with a tube. So all that you had to do was to you know fit the tube into the pump, and feed would be delivered to the patient. So it was a purely closed system. You didn't have to open anything. And now there is one formula by the name ready to hang, that is by Abbott. So that's a balanced protein formula, balanced nutrition, ready to hang. So it comes in a bottle, and they provide the whole paraphernalia along with that, which can be used and for feeding the patient. And then the position of the patient is very important. So we have to keep the patient's head up by 45 degrees to prevent regurgitation and aspiration, and position of tube has to be regularly checked. So why should we go in for pumps if possible? So pumps, you can actually deliver very precise volume. The rate can be fixed very beautifully. In certain patients, especially in pediatrics, because you have to be the very small amounts of feeds that have to be delivered to the patient. So if you just think of doing it through the gravity bag or maybe bolus, you actually cannot control that amount. So enteral pumps, they can help us with that. And but again, the limitation is that we can use pumps mainly only for formula feeds. If you're using a kitchen blenderized feed, pumps are no good, they do not help. So gastrointestinal problems, like they most problem, there could be factors which could be related to the feeding. So composition of formula also can be an issue that could cause gastrointestinal problem. Like a very malnourished patient, if fed on a very high formula, high protein containing formula, or very high fat containing formula, or if you add a lot of MCTs or a very MCT rich formula, the patient could have issues. And administration method, as to like at what rate and what's the volume of the feed that is being provided to the patient. And contamination, that can never be ruled out unless it is a closed system. So because even if it's a commercial formula, whether you do it at the bedside or in the kitchen, someone would mix it up with water. So some spoon or whatever you use, the utensil in which mixing is happening. So if that is not clean, formula contamination can happen. It happens. It's not something that can never happen. So diarrhea is most common gastrointestinal issue that can happen. That can be that we do encounter in most of our patients. And it but it's not always the feed that is the reason for diarrhea, but unfortunately yeah, it's the question. I mean, the type of feed is the first thing that is questioned whenever patient has a diarrhea. And so it's like a number of things that could lead to diarrhea. There could be concurrent use of antibiotics or some medication that could have induced diarrhea. The rate of feeding could have been excessive, and many times just slowing down the rate uh, and gradually pepping it up helps. Osmolality of the product you are using, because uh, most semi-elemental formulae, though the companies say that semi-elemental formulae can be very easily, and they should be used in patients who have a compromised GI tract, but they are slightly high on osmolality. So in my practice, I've felt that very commonly do I come across diarrhea in patients whom we feed semi-elemental product, unless we feed it diluted. So we have to dilute, at least I dilute it much more than what they recommend, and then we use it. So feeding method could be an issue. And if the patient is previously malnourished, and if you are, as an overzealous physician or a dietitian, you start with the total target calories on day 1 or day 2, the patient could end up with diarrhea. So we have to analyze the cause. If it's feed related, we can change the formula. We can even try changing the administration method. Patients who are on bolus feed and have diarrhea can be moved over to a continuous feeding, and it does help. And we have to check about the hygiene that has been, maintained. And even and in many ICUs and centers, patient has a diarrhea, and next 1 or 2 feeds are held up. So that's not the way. We should avoid unnecessarily discontinuing use of feed or formula. Rather, make changes in the administration method, or maybe decrease the volume to initially, and then pep it up later. So again, we have to review formula composition, because if you make, if you're not using the desired dilution, or trying to make it thick because you wish to give more calories and protein to the patient through that formula, through that feed, and administration method, the quality of the method, because many times I've seen, those, what we commonly see is this gravity bag, because when nurses, it has to be, used only for 24 hours, and it has to be changed every 24 hours. But in one case where the nurse thought that the patient was poor, she thought of reusing the bag the next day, and she just washed it with hot water. And while washing that, she ended up touching the tube in the sink, and she just placed the same, bag, and she was about to feed, and I noticed it, so I had it changed. So these kind of choti issues, they can, lead to diarrhea. And so you have to be very careful. And um, training of the nursing staff is very important in this respect. We do, like constipation, just as diarrhea, even constipation is pretty common. And so because most
Ritu, we can, these are all complications of the formula, no? I think we can just skip this.
Yeah.
Okay. Yeah, we can. The complications, probably they will take charge, no? The dietitian will take charge. Yeah. We can just move on.
So it's like when we're planning.
This one is important. Yeah.
So this enteral nutrition monitoring is very important. There is absolutely no fun, just assess patient once, and, design a nutrition support program, and just start feeding on the patient, and you do not monitor. Because you have to monitor as to whatever nutrition support is being provided. Is it okay? Is it enough? Because the patient's condition would change over the days, and similarly, because of the change in condition, his nutrient requirements would also change. So weight can be checked or assessed. If it's not possible to weigh the patient, you can look for edema, some symptoms of dehydration, whether whatever, feed you're providing to the patient, is it actually being delivered to the patient, some gastric residues, if you need to check, serum electrolytes, stool output, consistency. These are the things which have to be checked and monitored, and based on these, if there is a need to change the nutrition support program, it has to be done. It's not that once whatever you plan for the patient is just good for him till he or she gets discharged. Continuous monitoring is very important. So this is something I just wanted to, this is a very recent paper, this volume-based feeding versus rate-based feeding in critically ill. So it was published in, I mean, very recent means at least, Journal of this JICS 2019, where they compared rate-based feeding versus volume-based feeding. See, I'm sure we very commonly see that in our institutes, due to some other reason, maybe the patient has to undergo an endoscopy, tracheostomy, has to be intubated, has to be extubated. Today the patient had diarrhea, so the intensivist ordered for holding 2 feeds. I mean, today there was CT scan, so they end up holding feeds. So whatever we actually plan for the patient, I've seen that patient actually ends up getting only 60% of what he or she is intended to on very many days. So this rate based feeding versus volume based feeding, that means that okay, if it's like through pumps suppose you're giving and you decide on a rate that the patient has to be fed on, say it's just an example that 1 ml per minute or something like that, but then you have to see that for how many hours or minutes was the patient not fed, and you have to make up for that volume during the next feeding program. So maybe if you missed out, say 100 ml or 200 ml of feed during the day for due to some or the other reason, because of course testing and all those things are also important. So maybe you could increase that rate to meet up for the volume in the next few hours. So, and it was found that improved energy and protein provision with no adverse effects on glycemic control or GI tolerance. And so this can be actually practiced. And there's some guidelines like NICE 2020 guidelines and ESPN 2019 for liver diseases and critical care guidelines. You should all be thorough with these, because they are the guidelines that we all follow and to get good results. So conclusion on how to plan support would be that it's important to screen the patient on admission. Early nutrition should be provided. We should choose the formula based on the condition of the patient, and we should focus on catch-up feeds if need be, if we are missing up on feeds due to some or the other reason, and monitoring and evaluating the patient at frequent intervals is highly important. These are some three, I just added this slide today. These are the three, TPN products available. They were available in our hospital pharmacy. I just thought of mentioning them here. I'm sure there are many more. Like one is by Smoff Cabivin by Fresenius Kabi, right? So 1.1 liter of it would provide about 1100 calories and 50 grams of protein as amino acids and 38 grams of lipids. Then there is one Cabivin, which provides about 900 kilocalories with proteins, glucose, and lipids. So it's a 3-in-1 product. And then there's one Nutriflex Omega by Braun, which has about 1250 ml, would provide 1475 kilocalories, lipids, which are a combination of MCTs, soy, omega-3 triglycerides. That's how the name Omega Special, right? And glucose and amino acids. So there are many. It's just these three I came across, and I mentioned actually in our hospital, all that we do is that we are asked to calculate calories of these by the physicians. Ki hume itna energy protein dena, so you tell us how much can we give. So we don't go beyond this. So I couldn't do much on this. So before I start with CLD, ma'am, do we take up questions or how do we do?
How many more to go? You can just tell us one is how many more to go in each of these diseases. One is chronic liver disease, other one is pancreatitis.
I have CLD. I wrote. I have a few slides on chronic pancreatitis and NASH. So if you want, I can skip those. Are we running short of time?
No, time is okay.
No problem.
I'm already gone. I've taken a lot of time. So
no problem. I think these are more important, the practical ones. You can just tell us this chronic Please continue. Just continue.
Right. Okay. So when it, I haven't done any, paraphrase, basically only diet, and I'll be just taking that up.
Only diet,
So so when it comes to CLD, chronic liver disease, the diet has to be the macronutrients that have to be taken care of, like carbohydrates, fats, and proteins. So up to 65% of total calories can come from carbohydrates, and when we talk of fats, up to 30 to 35% of total calories can come from fat. And I've seen in most many dietitians, at least they do, you talk of liver and they think the diet has to be low in fat, and they end up actually going low on fat and going indirectly go low on carbohydrates as well, total calories. You're unable to meet the target. So up to 30% of calories as fats can be given. However, in cholestatic liver disease with steatorrhea, of course, we have to restrict fat, but we can supplement with medium chain triglycerides. Enough protein, high protein diet is very important in chronic liver disease, and because most of these patients would be sarcopenic and they would have decreased levels of branched chain amino acids. So, however, in recurrent HE encephalopathy, we may have to make some protein restriction, but then that's again temporary. For small amount, till the patient's sensorium improves, you can kind of restrict protein to some amount, and gradually again pep up the protein intake, and um, up to like maybe 2 to 2.5 gram of protein per kg ideal body weight can also be given. So when we talk of CLD, so now type of carbohydrate is also, type of protein is also very important. So when we talk of carbohydrates, usually vegetable proteins, because they are higher in fiber, have lower methionine, tryptophan, and cysteine, and higher like branched chain amino acid content. So they should be, vegetable protein should be preferred. But usually what happens is that only giving only vegetable protein makes the food very bulky.
Voice is low.
If the patient is on an oral diet, is this okay, ma'am?
Can't hear you.
Okay, so if the patient is on an oral, if the patient is on an oral diet, relying only on vegetable protein would make the diet very bulky, and as such patients are anorexic and unable to eat much. So mixed balanced diet with milk products, lean meats, eggs, and vegetarian sources of protein should be suggested. And we should not shirk away from adding protein rich formula, because most of these patients, as you just asked me, they would be eating inadequately. So in such patients, supplementing their diet with a protein rich formula uh, and with more branched chain amino acids makes a lot of sense. It would improve outcome. And salt intake is a very controversial kind of a thing that we often, because if you can see that even the guidelines, two major guidelines that we follow, IASL as well as ASLD, they one says that 3 gram of salt is all that you need to give, and the other says 5 gram of salt. So um, I've seen that what happens is that when we try to go very low on salt, we compromise the palatability of the diet. And because of that, the patient's food consumption highly falls to a large extent. So I really don't know whether at that point of, I feel that at that point of time, even this ESPN guidelines say that it's more important to provide enough nutrition than only looking at the salt side of the story. So in cirrhotics with ascites on a low sodium diet, morbidity and mortality rates were lower in patients receiving a balanced diet with VCCA or without PN support when compared to those recommended a low sodium diet alone. So a low sodium diet coupled with enough protein to improve the intake, be it through supplement or through oral foods, one has to ensure that CLD patients get enough protein and good amount of calories in the diet. And this, I don't think I should be taking this up, but yes, usually if there is dilutional hyponatremia, we may need to restrict fluids. Otherwise, there's actually no need to restrict fluid in these patients.
And you can just comment on the night snack of 200 calories. What should be given? They in cirrhotic patients, they say a meal just before going to bed of 200 kilocalories. So what can be given? What can be given for the 200 kilocalories?
See, for 200, fruit, like, a fruit chart maybe, right?
Okay.
So some banana and apple, if it's just a bowl full of fruit,
Fruits.
it
Okay.
would easily give 200 calories.
Okay.
They could, down south, I really don't know what commonly people would like, but see, poha, idlis, such kind of foods, and
Okay.
they're all good sources of this protein and calories. So those can be given, but usually fruits, or maybe I usually would ask custard with fruit, milk based, like kheer and such kind of desserts, because at that time usually people are used to
Like it.
having milk
Okay.
at that time. So you
Okay.
can even ask them to add a supplement to their milk, to make up for the calories, or just a supplement without milk, one drink. If we think of oral nutrition supplement, that can be given at bedtime, because it would be easier to make at that time also,
Sure.
rather than asking
Okay.
something, take something that involves a lot of cooking.
Move on.
And some supplements like, this we have to, of course, this vitamins and zinc and minerals and vitamins have to be taken care of. And okay. So, and when you talk of chronic pancreatitis, uh, a low fiber diet has to be preferred, because a high fiber content can absorb enzymes and retard nutrient absorption. About 25 to 35 kilocalories per kg ideal body weight of calories can be given. A high protein balanced diet, and we can resort to PERT if there is increased fecal fat excretion, and up to 25% of calories can easily come from fat, and you can use MCTs. And but usually no more than 50 grams of MCTs are not recommended, because they have their own limitation. Too much of MCT can be ketogenic. It is unpalatable. It can cause diarrhea, nausea, and abdominal pain. So recommendations for a chronic pancreatitis patient would be a normal, healthy, balanced diet, small, frequent meals. We need to restrict refined carbs and total carbs if concomitant type 2 DM is there. A high protein diet, moderate fat, and low fiber diet with lots of supplements. So, as the dictum says, that saturated fat should not exceed more than 10% of the total calories. Trans fats, by any chance, have to be avoided. And low fat dairy, fish, and poultry should be used as a source of good quality protein. And amongst fats, consumption of monounsaturated fatty acids and PUFA rich foods should be included. Uh,
You can
okay.
just move on to the
Yeah.
diet.
So when it comes to NAFLD, as per the guidelines, that even 7 to 10% weight loss can really help us with improvement in fibrosis. So in overweight, however, in overweight, NASH patients, we should not aim very too much of weight loss in a day. We have to go gradual, and along with, and we have to suggest increased physical activity as the first line of treatment. And Mediterranean diet is something that we usually suggest to these patients. And so exercise is definitely a must for patients suffering from NASH and NAFLD. And when it comes to Mediterranean diet, it basically is a moderate carb, high fat, and high fiber, high protein diet. So up to 50% of total calories can come from carbs, and up to 40% of total calories from fats. But the fat sources mainly is MUFA. So in Mediterranean side of they mainly use olive oil. So that's more of MUFA and omega-3 fatty acids that we have to include. Lots of fiber, high protein, more fish, and more vegetables and fruits, and absolutely no sugar or minimal processed foods, and especially no high fructose commercial sugar foods like syrups and all. So a low carbohydrate diet with lots of unrefined whole grains and fiber rich complex carbohydrates, more green leafy vegetables and low calorie fruits and vegetables, and avoid refined sugars and fructose corn syrup, because inadvertently most of our people, because all those fruities and mazas and roadside juices, most of these juices, they come as fruit juice concentrates. They have more sugar or fructose corn syrup than the fruit itself. So those have to be informed to the patient. And a high protein diet with a judicious mix of low fat dairy and moderate fat dairy with lean meats and fish, lots of fruits, lots of pulses and legumes to make up for protein, and low fat dairy and its products. Thank you. I'm really sorry I took.
No, you've done a wonderful job. You went through system. I mean, you've covered a lot. Actually, Varghese. She's covered almost entire. I think next time what we will do when we have a case, we'll move her in. So then she will tell us exactly how to manage a patient.
Then I may be because I felt it was too much. I wanted to do,
we will not leave you. Yeah, we will not leave you there. Yeah.
And then it'll be always a pleasure to be here. And acute pancreatitis, that would mainly be covered like a critical patient. So all that we discussed initially would hold good for pancreatitis.
At least you can take up some questions. Anyone can ask questions now. Be practical and sort out your queries. PGs, exams on 2nd. So anything you would like to sort out practically?
One question is how to formulate elemental diet for CD. I think that has already been discussed, no? What formula you use in a patient with hyponatremia?
Hyponatremia. So you want to correct? See, usually these hepatic formulae, they are low on sodium, right? So, and even renal formulae. So we don't have to use only hyponatremia. Usually there would be some other disease also. So you have to see what you want to. In fact, that patients with the hepatic insufficiency or CLD, people write just because these high protein formulae are written to them without realizing that very high on sodium. Okay, so maybe a hepatic formula which is high in protein should be suggested to such a patient. But if there is a regular patient with hyponatremia, many times just giving a formula enough doesn't help. So you have to top up sodium, salt in the feeds. So that would actually
always be a secondary cause for the hyponatremia, which needs to be sorted out, no? Rather than giving a supplemental diet for the sodium.
Yeah, that will be a problem.
Yeah.
So that's the question. When we calculate the protein for a chronic liver disease patient, the number of teaspoons or scoops to be added are very high based on the number of protein in the formula, and the patient does not tolerate so much. How to go about this?
They say 5 scoops, no? They say 5 scoops per meal. So that's a huge amount. So how do you recommend your patients in Ludhiana?
Actually, the thing is that, you can't always go by what they write.
Right.
So we have, first of all, it's the volume also that is important, how much we want to feed. Because if it's like, somewhere limited amount of volume is to be fed, you are actually not able to meet patient's requirements, because you can't incessantly go on and on adding formula to concentrate, because then that will have its own implications. You could end up with diarrhea. So in that case, I think we have to gradually pep up the volume if possible, and similarly the amount of protein powder. But yes, if the patient is totally on formula feed and you want to give a very high amount of protein, you can, provided there is enough volume, right? So I've seen that usually if you feed about 150 ml of feed every 3 hours, so 8 feeds a day, I'm able to give about 150 grams of protein to the patient if need be, but then I have to balance it again. Okay, alone high protein formula all alone, you would give protein, but then what about calories? You have to give those also. So it has to be blended. So it's like you can, I mean, at times we're not able to. It will actually depend on the volume also.
Volume has to be maintained in chronic liver disease. You can't exceed the volume also. Yeah.
So if we cannot exceed, then we have whatever best we can give, we try to feed that.
That's a question about rematin in IBD. I think it's a diet name, no? Rematin.
Yeah. Rematin is actually not available now, so I don't think we should be talking about it. But
okay.
They've taken it off shelves. But there is a new product that is Fullite CD, so that's available. And but from whatever we have experienced, though these are special products for CD, we have used regular polymeric formulae for our Crohn's disease patients, ulcerative colitis patients. We have done acute severe UC.
How do you manage them with right stick feeding or oral feeding? The Crohn's disease
Most of the
patients.
patients were on oral feeding. Just a few have been who were in ICU. They were even on tube feeding. But most of them, the one on exclusive enteral nutrition for CD, they have been on oral diet. And then I've even done a few kids on this oral EN, and they've all done very well. And see this when I talked of Pediasure Advanced versus only Pediasure. Similarly, there is Ensure and Ensure Plus. So the names are same, and one doesn't realize the difference. So one is gluten free. Suppose Ensure and only Pediasure is only gluten free, but it has lactose. So when it is at Pediasure Advance and Ensure Plus, they're gluten free as well as lactose free. So in CD patients, I mean, depending whether you want to give a lactose free diet, so you have to choose the product accordingly. And we all our patients have done very well on polymeric formula. We've used a lot of Ensure Plus.
So recommendation for Crohn's disease would be more of a polymeric rather than elemental.
Yeah, polymeric does well. We have you could give semi-elemental, but then what's the fun? It's I'm not as palatable as polymeric, less variety, more expensive. So there's no need unless your patient has some issues with polymeric. If there could be a patient who doesn't do very well on polymeric, and you might want to shift that patient to a semi-elemental one. But then that's again, you have to try doing it.
There's a question about dilution. Most of the complications are related to concentration of the formula. So if you dilute it, well, will the complication be less? So how will you dilute the formula to prevent complication? That's one question.
Most these commercial formulae, they come with the standard dilution mentioned on it with the osmolality, right? So if you can stick to that, there's absolutely no issue. But in many patients who are undernourished or even otherwise, at times even those standard dilutions, with those dilutions, we do end up having some complications. So what we can do is that initially you start at like suppose, okay, if they say that 100 ml of plain water can have 20 grams of a particular formula. Okay, so this is how we feed. But then maybe if you think of the patient has,
you are less audible.
You can start with 10 grams of formula in 100 ml water for a day or two, then make it 15 grams, then make it 20 grams.
Okay,
So this
gradually.
is the tolerance improves, yes.
There's a question that a patient with a chronic liver disease as well as a nephrotic range proteinuria, that means two conditions which will produce hyperproteinemia, how to estimate the protein intake? Yeah. That means already CLD plus in addition some renal problem producing loss of protein as well.
See, in most, as such, we do not recommend very high protein diet. I mean, just to make up for that loss. But as such, but yes, usually what happens is that the moment a patient sees that the kidney function is not normal, then they tend to go into a lower protein intake. Whereas I feel that that actually will not help much. So in that case, it's actually the judgment of the physician or the dietitian, I would say, that comes handy. The experience that how much you actually want to feed. I would never like to go below 1 gram protein per kg body weight for my patients, such patients. And gradually, of course, anything between 1 to 1.5 does well for these patients.
Now I have some personal doubts. How long you will continue the ketogenic diet in a person who want to lose weight? Because there is a limit to which you can, they want to stop it and start eating fairly normal food. So what is the advice for them?
See, for one thing that this ketogenic diet for weight loss is a very, very recent thing. Or I think only past 3 or 4 years, it's become I wouldn't say it's fad, it is scientific, but unfortunately, people in India are not following it the right way, and more so in our kind of eating pattern. It doesn't really fit well if we have to do it over long period. See, when I travel abroad for ketogenic diets, I meet people, John Hopkins faculty and all, who've been on kind of ketogenic diet, low ketosis, right? Not very high as we go in for epilepsy. So they've been used to eating 2 or 3 meals a day, and they eat a lot of non-veg. So their diet is automatically low on carbohydrates. In Indian scenario, staying on a ketogenic diet for long practically becomes very difficult. But if you have resorted to ketogenic diet for weight loss for a few months, say, and you immediately want to shift over to a normal diet, all your weight will rebound. So that's not the way. It has to be done gradually. Usually, like suppose you are on a 20 gram protein, 20 gram carbs, 20 gram carb diet initially, and then maintenance dose would be 40, then you shift over to a 40 gram carb diet, and then to a 60 gram carb diet. And when it's like 60 gram carb diet is something wherein you can include some bit of cereal in your meals. And so you have to stick to 60 to 80 grams. It has to be a low carbohydrate diet forever, maybe not very high on fat. See, because for weight loss, we don't need exactly a very high ketosis. Very mild ketosis is needed. So, and that's quite practically possible if planned. You would need the help of a dietitian for that. I don't
Okay.
think anyone should try on, yeah.
Yeah. I think dietitian advice is professional advice is required.
Very important in this, and that to a trained keto dietitian. Because there's so many, there are very few of trained keto dietitians in India. But because most of the information comes from the internet, right? And so people do go wrong. There was a death also, no, down south, that actress who died due to ketogenic diet. So probably she followed some internet advice and did it. So that's not the right thing to do.
There are a few more questions. I will take 2 questions more. A parental nutrition bag usually has about 1,100 calories, and it has to be infused over 24 hours. How do you plan? What's the duration of the infusion?
No, it's not a must that you have to give it over 24 hours only. So you have to decide on the amount of calories that you can get, that you actually need to feed the patient. And even in parenteral nutrition, you have to go the same way. You don't have to meet the target the first day, right? Many times parenteral nutrition comes along with enteral. So in that case, maybe you would give partial target, you a partial amount of nutrients from enteral, and in that case such maybe just this 1,000 calorie parenteral bag would be enough, because you're giving the rest through enteral. And if there somehow enteral nutrition is not feasible and it's only parenteral, then you may have to resort 2 bags a day. You have to see how much you want to feed, then you have to adjust the rate. And but definitely don't try to do all of it in a single day, because parenteral nutrition has its own complications which are much more than enteral nutrition, so you have to go slow instead. And I just
There's a question regarding that.
there would be many more preparations available, and you can choose accordingly.
In an NAFLD patient with a near normal BMI, is there a need for a diet advice or simply
Yes,
exercise?
definitely. We have a lot of lean NAFLD patients. So even they need, of course, in their diet, we don't really need a lot of weight loss, I mean, in those patients, but mild weight loss is definitely aimed at, and diet modification is very important. We have to restrict, cut down on the protein, carbohydrate intake. We have to increase their protein intake and the amount of fat and the type of fat, and we have to add a lot of fiber. So those modifications in such patients, lean NAFLD, modification of diet to alter these macronutrients is very important.
One more question, that you told about the problem of salt restriction in a patient with cirrhosis with ascites and edema. And down south in Kerala, I have noticed Ayurvedic people using mountain salt. That is that contains more of potassium. Okay. So does it offer any advantage? Have you ever tried this? I have never thought of it doing a trial, but I have seen them using this, and it is palatable. Not the same taste as the common salt, but I think still acceptable.
Yeah, no, it does help, because obviously it's the sodium that we are trying to cut down on. So if you give that rock salt, potassium can be I mean, it's mainly a potassium salt, so it does it does improve a bit of palatability. Rather than a plain low sodium diet, a no salt diet, it's always good to add that. But then we have to take care, because see, if the patient is has some renal insufficiency. There could be a
Potassium
potassium also
problem.
could be an issue.
Potassium problem.
Potassium could be an issue. So that again, in that case, we cannot recommend that. Then there are also salts like, low sodium salts. So people think that they have ascites, so they can switch over to low sodium salts. But unless they use the prescribed amount, right, they'll go wrong. Because what happens is the taste, that namkeen taste is because of sodium, right? If they just go on and on adding more salt, thinking that it is low in sodium, they would ultimately end up taking more sodium.
Yeah.
With the taste. So, I mean, the patients have to be really counseled. They have to be told why low sodium salts may not be a good option, or if at all they have to be used, how much should they be used, or if they can, whether they can use rock salt or not.
So thank you very much. It has been a great session, and personally,
Thank
I
you. Yeah.
learned a lot.
Yeah, we learned a lot. Exactly. It's all been recorded. So we'll listen to it again. Thank you, Ritu, for a wonderful, wonderful session. And thank Dr. Ajit Sood for allowing you to participate in a session down south. But I think most of the people are appearing for exam. So I think many of them who wanted to learn about this are there with us.
I really hope it helped.
Thank you. Yeah. Thank you once again. And best wishes to all the students. Okay. All the best.
Yes,
And the last class of the session will be on 31st. It's an X-ray, again a non-interactive one, and the records will be available on the Facebook as well as YouTube. So with this, we will wind up today's session. Thank you once again for all the faculty and the residents. Thank you, Ms. Ritu Sudaga and Jayanti ma'am for the session. Thank you. Good night.
Thank you. Bye. Bye, Ritu. Thank you so much. Thank you. Thank you, Viti. Thank you.